Welcome to AETCM, the emergency medicine channel. Shall we start now? A 45-year-old male came to ER with complaints of abdominal pain, abdominal distension and vomiting since last 3 days. On initial 10-second assessment, airway was patent, no pooling of secretion or gurgling of sounds. Breathing SpO2 99 in room air. Respiratory rate was 15 rate per minute. Circulation, heart rate was 108 beats per minute. BP 130 by 80 mmHg. Coming to disability, GCS was E4, V5, M6, GRBS 98. Exposure febrile. Pain score was around 7 by 10 and according to WHO pain score, we had given him injection PCM 1 gram IV stat. Adjuvants to primary survey, we took a CBC and VBG point of care. In VBG, pH was 7.416, potassium was 4.1, sodium 138, creatinine 1.8 and lactate was 1.2. Coming to CBC CRP, total count was 9.5, HB 15, platelet 2,68,000, CRP was 21. Coming to sample history, a 45-year-old came to ER with complaints of pain in abdomen, which was continuous colicky type, more around the umbilicus initially, later became diffuse abdominal pain. Pain was non-radiating, aggravating on taking food and there is no relieving factors. Also complaints of non-projectile bilious vomiting of multiple episodes mixed with food particles which aggravated on taking food since last 3 days. Patient also complains of abdominal distension which was gradually progressing since last 3 days. History of no passage of stools or flatter since last 3 days. Patient had an history of open appendicectomy 5 years back. No history of bleeding or mucus discharge per rectum. No history of umbilical discharge. No history of weight loss. Patient has no comorbs. Patient had no allergic history. Last food intake was around morning 9 a.m. post which he had vomiting again. Coming to systemic examination, per abdomen examination, abdomen was distended, generalized tenderness was present, no guarding, no rigidity. On auscultation, sluggish bowel sounds present. Coming to CVS, S1, S2 was heard, no.
Yes, so there was generalized tenderness and guarding rigidity, but was not there.
Not there.
What if it was there?
We'll have to suspect peritonitis.
Perforation. Okay.
Coming to CVS, S1, S2 was heard, no murmurs. Respiratory, bilateral air entry was equal. Coming to CNS, no focal neural deficits. Now adjoins to secondary survey, we took an X-ray erect abdomen.
Okay, so what were your suspicions at this point of time?
Since the pain was...
It is a 44-year-old male patient. Okay. Complaining of?
Abdominal pain, vomiting, obstipation.
Okay, constipation, obstipation is also there. And it was an intermittent type of pain. Okay. So what all did you keep?
It can be mesenteric ischemia, abdominal obstruction, or it can be already appendicectomy was done. It can be stump appendicitis causing peritonitis, or cholecystitis or
cholecystitis can be there. Okay. Okay, so why you did a VBG, a blood gas for this patient?
Patient had recurrent episodes of vomiting to see any metabolic alkalosis or adynamic ileus potassium.
Potassium will be low. Then what else can you check?
Usually in if we are suspecting obstruction, abdominal obstruction, patient can have dehydration and increased lactate in mesenteric ischemia also can be.
Dehydration will not cause high lactate, but because of the muscle involvement there can be high lactate, but usually lactate will be elevated in case of mesenteric ischemia. Okay. Then in case of uremic gastritis like symptoms, creatinine might be high. So this much things you can check in the blood gas analysis. And why CBC CRP was asked?
If is there any signs of peritonitis, then CRP will be elevated. Okay. If gangrenous bowel also, then CRP will be elevated.
Okay.
Okay. We took an X-ray erect abdomen. It showed dilated small bowel loops of more than 3 centimeter.
Okay.
We kept the patient in
Small bowel loops, dilatation of more than 3 centimeter. Okay. What is 369 rule?
Small bowels more than 3 centimeter, large bowel more than 6 centimeter, cecum more than 9 centimeter will indicate dilated.
Okay, so in case if you are taking an X-ray abdomen erect and we need to measure how much all these intestines, small intestine, large intestines diameter is, and if at all the small intestine is more than 6, small intestine more than 3, large intestine more than 6, and if cecum more than 9, we need to suspect intestinal obstruction of that particular area. All will not be dilated, either one, if any one is positive. Okay, and what else will you check in X-ray?
Gas under diaphragm should be checked.
What was there in this patient's X-ray?
Dilated small bowel. Gas was not there under diaphragm.
What X-ray was it?
Erect abdomen.
Erect abdomen. Okay. Okay. What if the patient is not able to stand up?
Then lateral decubitus X-ray can be taken.
Okay. So was there any multiple air fluid levels or anything in this
No.
X-ray? Okay. So what type of obstruction this can be? How will you differentiate between each obstructions?
Small bowel.
Based on the X-ray.
Small bowel and large bowel X-ray. Volvular convicts can be seen in small bowel. Large bowel hostrations can be seen.
How will you differentiate between this valvular convictus and hostration?
Step ladder pattern will be seen in small bowel obstruction. Picture frame will be seen in
small bowel. If it is dilated, it will be mostly towards the center. Large bowel towards the side. Then valvular convictus, will it be fully? It will last from the one end of the bowel to other end of the bowel, whereas hostration will be incomplete. Okay. So there was dilated small bowel loops. And how much length?
Centimeter was more than 3 centimeter.
More than 3 centimeter was there. Okay. What else will you check in the X-ray? Then you will look for air under the diaphragm. Multiple air fluid levels. Then
we'll see loaded colon is present.
Yeah. Then X-ray, if at all it is because of any gallstone ileus and all, you might see the gallstones in the X-ray, and if at all it is because of the gallstone ileus, mostly gallstone will erode the gallbladder and come and become stuck in the ileus, that region. So we can see any air along the liver area. If at all any air is there, that means there can be some little bit amount of hemobilia, that thing, if at all is there, we'll be able to see. And if at all the bowel, you told the bowel loops are dilated. So bowel loops, as it becomes dilated, what will happen? The blood circulation to that area will get affected. Edematous will be can affect it. Sometimes there we can see some amount of air pockets around the bowel wall. Some amount of air pockets because of the gross dilatation. Some amount of air can be seen along the bowel wall, and as you told, fat standing also can be seen. Okay.
We kept the patient in NPO. Nasogastric tube was arranged and inserted with continuous RT aspiration.
So this patient you diagnosed as intestinal obstruction. So why this patient developed intestinal obstruction?
Causes of small bowel obstruction, most common is due to adhesions, or it can be due to incarcinated or strangulated hernia. But here patient did not have any hernia, but he had an history of appendicectomy 5 years ago, open appendicectomy, but reports were not available what exactly happened during that time. So it can be due to adhesions causing
So since this patient had a history of surgery, appendicectomy, it can be, one cause can be adhesion. Then any other cause?
It can be due to polyps, intraluminal causes, or gallstone.
Because of this surgery particularly.
Adhesion.
So if no, always this is appendicectomy, so it is very unlikely to have any other complications. But if at all the patient had a bowel surgery in the past, we need to suspect strictures also. Strictures can be there. Not only adhesion, strictures can also happen. Then other than surgical complications, then there can be foreign bodies and all. Okay. So whenever you are getting an intestinal obstruction, how will you classify it?
It can be dynamic or adynamic. Dynamic, there will be peristalsis happening against a mechanical obstruction. In adynamic, there is no peristalsis at all. It can be due to paralytic ileus, post-surgery or dehydration, or due to reduced potassium, or it can be due to mesenteric ischemia or embolism. Dynamic is mainly due to...
And it can also be because of some drugs. Anticholinergic drugs. Okay. Dynamic because
of mechanical obstruction. It can be intraluminal or external.
Okay.
It can be either small obstruction or large bowel obstruction. Small bowel obstruction causes are mainly most common adhesions or due to hernia or due to presence of polyp or lymphomas. In large bowel, it's mainly due to Crohn's malignancy or ulcerative colitis or due to volvulus or diverticulitis.
Okay.
Or it can be acute, subacute or chronic obstruction also.
Okay. So you told that this patient came with vomiting. How else can a patient come to us?
Depends. In small bowel obstruction, usually we'll see vomiting before constipation. Patient can also come with obstipation without
so
vomiting.
what kind of vomiting? So patient is telling you a history of vomiting. What else will you ask?
If it is projectile or non-projectile, if it is bilious or non-bilious. Usually intestinal obstruction, small bowel will see bilious vomiting because it will be below ampulla of water.
Okay. Then if it is a large intestinal obstruction?
Constipation will be seen before vomiting.
Constipation will be seen. Then what will be the type of vomiting if it is a large intestinal fecal and vomiting will be there. Okay. Okay, then you told that this patient it didn't have any, this patient had obstipation and constipation. So what was the bowel sounds in this patient?
Sluggish.
So can a patient with intestinal obstruction have bowel sounds?
It can. Sometimes it can be increased in mechanical obstruction also due to continuous peristalsis. But later on, after so much dilation, peristalsis might stop and the bowel sounds can become sluggish, later on reduce, and there won't be any bowel sounds.
And even and if it is partial obstruction also, you can hear bowel sounds. Okay.
Now coming to management, we kept the patient in NPO.
Okay, so what is the role of ultrasound abdomen? If at all you don't have an X-ray, bedside ultrasound if you are doing, when will you consider it as significant? What will you see in an intestinal obstruction ultrasound abdomen?
We can look for dilated bowel sound also. We can look for peristalsis in ultrasound.
Then?
And if it is intraluminal, we can look for fecolith presence or
you can anyway look for gallstones can be checked. Then we can
fat
look
stranding also can be checked.
Then vascularity can be checked
to rule out mesenteric ischemia.
Beyond how much dilatation will you consider as significant if it is in ultrasound? In ultrasound only 2 centimeters is required. If at all this thing is more than 2 centimeters, then we can consider it as positive result. Okay. So ultrasound can be, investigation, better to do an X-ray abdomen, right? If at all we are not able to shift the patient, we can do ultrasound. Okay. So management, when you are talking about management, tell about investigations also. So first we will have to, so this patient presented to us, so first we will have to do the lab, then the imaging. So lab, what all things will you send for this patient?
Lab, CBC, CRP has to be checked. CRP more than 20,000, we have to suspect if leukocytosis is there, we have to suspect strangulation or bowel ischemia leading to peritonitis, or perforation has to be ruled out with CRP.
So why this infection is coming?
Due to peritonitis or strangulation.
Peritonitis is happening because if at all there is an invasion to the peritoneum, that means especially when there is a perforation. So perforation can cause peritonitis.
And this food getting stuck also becomes for the bacteria and...
Okay, so food is getting stuck, that area there will be all the secretions will be coming, that area will get infected. then the bowel wall also will get infected. Okay. Then in case of gangrene also the CRP will get elevated. So in order to look for any perforation peritonitis or just intestinal obstruction causing infection or because of the lumen involvement, we will have to look for CBCRP. If there is necrosis also, CRP will worsen. So CBCRP, then
serum electrolytes has to be
electrolytes. What all electrolytes?
Potassium, sodium.
Potassium can be low in case of a
Paralytic
ileus, and also secondary to vomiting also potassium can be low. Okay.
Chloride also has to be checked because of vomiting. Chloride can reduce. And
then what else will you check? So when CBC, CRP you told, so we will have to also check for the hemoglobin and hematocrit because of the vomiting patient will go for dehydration. So hemoconcentration will be. So hematocrit will be elevated. And we will have to look for any renal function test also because patient can go into pre-renal failure. Okay, either because of infection AKA or pre-renal failure. So that also should be checked. Then blood gas we already discussed. Then imaging wise, X-ray abdomen rectant,
CCT abdomen.
CCT abdomen. Why? What is the requirement for a CCT abdomen?
To look for the transition point. If there is any transition point, it will help us to find the transition point.
Okay, then
obstruction.
Cause of obstruction we will be able to find. Transition point we will be able to find. And vascularity also. Okay. Okay. Then ER management. What will you do in ER?
First, we'll keep the patient in NPO.
Okay.
And if he had not taken food from very long time, his GRBS might go down, and we'll have to provide patient with either IV fluids or DNS according to the GRBS.
Okay.
And according to if the patient will have to look for IVC. If the IVC is collapsed, then we'll have to give fluids to the patient. Usually with intestinal obstruction, the bowel wall will become more edematous and reabsorption of water doesn't happen, and along with that patient has recurrent episodes of vomiting and he's not taking food, so there is high chances that he can go into dehydration. As you told, he can go to pre-renal failure and all. So we'll have to give fluids to the patient. Then patient might have pain, then we'll have to give antiemetics and analgesics to the patient. Then usually most of the intestinal obstruction are treated conservatively, but if presence of peritonitis, strangulation, or the patient is not maintaining with conservative treatment, then we'll have to think about surgery.
Okay, so what is the role of Ryle's tube insertion?
Decompression of the gastric contents.
Decompression of what gastric content? The proximal content. Somewhere there is a block, and because of that the proximal area is dilated, and lot of air and the food particles and also bile and pancreatic secretion is getting accumulated.